Hey all, welcome back to the Real Life Pharmacology podcast. I am your host, Eric Christensen, pharmacist. You can track me down on LinkedIn is a good way to find me. Also through the website reallifepharmacology.com. Hit the contact button and send me your thoughts on whatever it is you'd like me to hear about. So with that, today I'm going to cover Pioglitazone, and the brand name on this medication is Actos. Used in the management of type 2 diabetes. That's really the only thing I've ever seen it used for in clinical practice from the classification TZDs. And really, pioglitazone is the only drug at this point left in this class. Rosiglitazone was basically pulled off the market due to risks of cardiac problems and things of that nature. So, with that, in the management of diabetes, lowering blood sugar, how does it do it? What is its mechanism of action? So mechanism of action, if you ever see this on your pharmacology exams, it's an agonist at PPAR gamma. And that has multiple different effects, but basically alters glucose and lipid breakdown and various other things. But primarily, I think what's remembered most is that it improves the response to insulin, and particularly reduces insulin resistance out in the periphery, in the muscles and liver and things of that nature, and allows blood sugars to go down through that mechanism. So when I think about that mechanism, I do always remember that it does not stimulate the release of insulin. So, you think of sulfonylureas, they actually stimulate the release of insulin. And drugs that either are insulin or stimulate the release of insulin have a higher likelihood of hypoglycemia. So, pioglitazone, by itself, probably not a really strong potential to produce hypoglycemia. Now, if you're using it in combo with another agent, like insulin or the sulfonylureas, like I mentioned, then it's probably a little bit higher risk type of situation. So kind of coupling in, let's pull in some of the side effects and the issues with pioglitazone, because it's really fallen out of favor. It's very seldom that I see it used anymore. And, it may have been due to all the negative press as far as rosiglitazone. But probably one of the biggest disadvantages is it can cause weight gain. So in management of type 2 diabetes, these patients are generally overweight already. Adding a diabetes medication that causes weight gain, not an ideal thing to do. So that's definitely a disadvantage. The other probably major side effect, big disadvantage that you're going to see in practice is this side effect of edema. And coupled with that, the possibility of exacerbating heart failure. So there is a boxed warning on this medication that patients who have symptomatic heart failure, this drug is absolutely contraindicated. So, and specifically, New York Heart Association class 3 or 4. But if I see a patient with a diagnosis of heart failure, it's pretty much the last diabetes drug I'm going to think of wanting to try to give a patient. So those are kind of the downsides of the medication. A couple of potential advantages that are good for diabetes patients is from an adherence perspective, it is only once a day. And also from an adherence perspective, it is inexpensive as well. So some of the newer agents, which can, maybe help with weight loss and things of that nature, which are really good for type 2 diabetes, like the GLP-1 agonists, for example, maybe the SGLT2s, at this time, those are really, really expensive agents. And if insurance coverage isn't adequate or things of that nature, that can really be a big downside to some of those medications. A couple of other side effects that I've seen come up, I've had asked questions about bladder cancer. So this is something that has been, probably blown up in the news a little bit. I've seen some evidence that maybe shows a slightly higher association, but I've seen some evidence that says, maybe not. So this is probably an ongoing area of research. With that said, if you've got somebody with active bladder cancer or a history of bladder cancer, if we've got another option available for type 2 diabetes, which we often do, you're probably generally going to avoid this. Again, until we maybe see more kind of conclusive evidence one way or another. But that is something that comes up. So a lot of clinical common sense, if we've got other options we can use, and we're worried about an at-risk patient for cancer or something, bladder cancer, then we're probably going to avoid it. If we get more evidence on that, I might change my mind and maybe, more or less concerned about that, depending upon where the evidence leads us there. One other thing that comes up is maybe a slightly increased risk of bone fracture as well. So patients at risk for osteoporosis, maybe they're on chronic steroids already for some other condition or something like that. You might think about that bone fracture risk a little bit with pioglitazone. Again, very, very rare things that come up. But definitely things that I have heard of from time to time. Let's take a quick break from our sponsor, and then I will tackle drug interactions with pioglitazone. If you're in the market for Naplex, BCPS, BCGP, BCACP, definitely check out meded101.com/store, STORE. It has a great list of resources. We got books, just good clinical information that can really help, nurse practitioners, PAs, pharmacists, of course, and students, become better clinicians and better at managing medications and using medications appropriately. So go check out those resources, help support the podcast at the same time. Greatly appreciated at meded101.com/store. Moving on to drug interactions. With drug interactions, pioglitazone, I don't generally strongly think there's a ton of drug interactions, but there are a few that may come up from time to time. One of the first things I think about is that risk for edema, risk for exacerbating heart failure. We're probably not going to want to use this drug in that situation anyway. But I do think about drugs where, maybe we're on a low dose of pioglitazone and we add in maybe an NSAID, or patient starts taking pregabalin, or maybe they start taking amlodipine for hypertension. Again, these are drugs that can kind of have additive effects on the edema side of things. So something I definitely watch out for if I see a patient that maybe has had an increase in furosemide, or maybe they just started a loop diuretic for fluid retention. Something you need to think about as far as that prescribing cascade and the risk of polypharmacy. Some other drug interactions. So I mentioned, I kind of hinted at hypoglycemia risk if you've got a patient on insulin already, or you're adding insulin and they're on this drug. Same thing with sulfonylureas. That may increase that risk of hypoglycemia a little bit. You may have to watch them a little bit closer as you're changing those type of agents. A few others, trimethoprim, combination in sulfamethoxazole, trimethoprim, or Bactrim, does inhibit 2C8. And that is the enzyme that is at least partially responsible for breaking down pioglitazone. So you may see increased concentrations of pioglitazone, maybe at more risk for some of those side effects. Gemfibrozil is another example that has some inhibitory effect at 2C8. So that's another one that I kind of think of. Again, the likelihood that somebody's on pioglitazone and gemfibrozil probably isn't very high because the drugs aren't used incredibly often, but it is something to think about. Clopidogrel is another one, brand name Plavix there, that can potentially increase those pioglitazone concentrations as well. So that kind of wraps up, I think, important drug interactions. As always, with drug interactions, I highlight a few that I think are notable. There's generally a laundry list of medications that can cause drug interactions, so be aware of that I'm obviously not covering every single drug that could cause an interaction, but just want you to be alerted and aware of some of the common ones that may be out there and may impact our patients clinically. With that, go check out the website, reallifepharmacology.com. Snag your free top 200 study guides, a 31-page PDF, where I highlight really, really important testable things. So obviously a great resource for anybody, taking any sort of board certification exam where, pharmacology, pharmacotherapy is covered. So go subscribe, get that absolutely for free, simply for following the blog there. Support sponsor, meded101.com/store. We've also got a couple of free Audible books there if you've never been an Audible member. So you can get your free book, your first book, absolutely free. So a really cool deal just to try out Audible. And you can get 6-8 hours of Audible clinical content that you really can't find many other places. And then if you loving the podcast where you're listening, those ratings and reviews definitely appreciated. Thank you to all of those who are still listening to the podcast and have already done that. I'm incredibly appreciative of helping to grow our audience. And of course, share us with a friend as well. Colleagues, professors, classmates, all those folks that need to know pharmacology and like the clinical side of things there as well. I'm going to sign off for today. Thanks so much for listening. And you can track me down on LinkedIn or at the website, reallifepharmacology.com. Have a good rest of your day.